Good evening to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker doctor for today's session. With much pleasure and honor, I would like to welcome a very renowned Dr. Bharat J. Parmar. Sir is a professor and head of pediatric department. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is neonatal jaundice. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over this session to him. Over to you, Sir.
Okay. First of all, thanks for your kind words. And also, I'm very thankful to Quillnet for giving IGCP group give opportunity to highlight my views regarding neonatal jaundice. Next, the jaundice is a common cause of the parental concern in newborn, though most of the cases are benign and transient due to the developmental immaturity in a bilirubin metabolism. There is a physiological jaundice rather than pathological disease. However, it is essential to differentiate physiological from pathological jaundice, as in a later case, bilirubin level may rise dangerously high level and cause neurological damage, that is kernicterus. Physiological jaundice is a sign of developmental immaturity in bilirubin metabolism seen in 50% of full term and 80% of the preterm. Cardinal features of physiological jaundice are the onset beyond 24 hours of birth, that is normal between 48 hours to 72 hours, and the maximum intensity of physiological jaundice on the fourth day, that between 5 to 6 days in preterm, and the maximum serum bilirubin less than 12 milligram per dl, and it is less than 15 milligram per dl in preterm baby. And this jaundice disappear by 10th day, but in case of preterm, it disappear on the 14th day, and the absence of other problem in the physiological jaundice. The age of onset in the neonatal jaundice. Within the 24 hour of the birth, the causes of neonatal jaundice are hemolytic disease of newborn due to RH and ABO incompatibility, intrauterine infection, congenital hemolytic anemia, there is a thalassemia major, maternal medication, there is a vitamin K and sulfonamides, and the Crigler-Najjar syndrome. While the jaundice between 24 to 72 hours, the causes above plus physiological jaundice and exaggerated physiological jaundice. Between 72 hours to the 14th day, all above cause plus breast milk jaundice, septicemia, gut stasis, and sterilization, there is a pyloric stenosis, idiopathic pyloric stenosis, and antibiotic therapy. The beyond 14 days of life, the causes of jaundice in neonate, there is a neonatal hepatitis. It is idiopathic or secondary, and also due to biliary atresia, there is extrahepatic biliary atresia or intrahepatic biliary atresia. The diagnostic approach for neonatal jaundice. The neonatal jaundice may be physiological or pathological due to many causes. Whether it is physiological or pathological, the neonatal jaundice is considered as pathological in the presence of following features. When the jaundice appear Within 24 hours after birth, it is pathological jaundice. When serum bilirubin more than 12 gram per dl or 15 gram per dl in preterm, it is a pathological jaundice. When there is a persistent of icterus more than 10 days and more than 14 days in preterm, it is a pathological jaundice. When the child newborn baby is sick, presented with vomiting, lethargy, poor feeding, apnea, and hypothermia, then it is a pathological jaundice, whether predominantly unconjugated or a conjugated. Pathological jaundice may be broadly divided into unconjugated or indirect hyperbilirubinemia and conjugated or a direct hyperbilirubinemia. The conjugated hyperbilirubinemia is relatively less common and usually manifests beyond 2 weeks of life with a progressive icterus and the typical clay color stool. So, what is precise cause? Although varied etiology, the most common cause of pathological jaundice, it is due to hemolytic disease of newborn. There is RH and ABO incompatibility. Also due to septicemia and congenital hemolytic anemia, there is a thalassemia major are the leading cause of unconjugated hyperbilirubinemia or jaundice, while conjugated jaundice or conjugated hyperbilirubinemia, it is due to extrahepatic biliary atresia or neonatal hepatitis. What is severity? Although serial bilirubin level are a best indicator of severity in neonatal jaundice, the criteria for clinical assessment of severity of the jaundice. So, by clinical evaluation, the age of appearance, severity and course of icterus, the perinatal problem, there is a preterm asphyxia and septicemia, and general appearance and activity of the newborn, and the relation, feeding related problem, there's a breastfeeding and the exposure to the drug, they cause it hyperbilirubinemia. So clinical assessment of severity of neonatal jaundice, there is a Kramer's criteria. There is when there is a bilirubin, it is 5, they appear on the face. It is 10, appear on the upper and the lower trunk, and in the palm and sole there is a 15. Investigation in case of neonatal jaundice. The baseline investigation in all the case, they include serum bilirubin, there is a total bilirubin and direct bilirubin, blood grouping, there is a ABO and RH typing, hemolytic screen, there is a hematocrit level, hemoglobin and peripheral smear, and the sepsis screen, there's a total leukocyte count and the differential count and the band cell count. Investigation in indirect hyperbilirubinemia, there is a serological test for torch infection, intraocular infection, hemoglobin electrophoresis for thalassemia major, osmotic fragility, G6PD estimation in congenital hemolytic anemia, metabolic screening for an enzyme defect, and the investigation in a direct hyperbilirubinemia, there is a hepatobiliary scan and the liver biopsy. Diagnostic algorithm for the neonatal hyperbilirubinemia. So the pathological jaundice, if it is yes, then the Coombs test positive, and then mostly it is RH and ABO incompatibility. If the blood group mismatch, there is a negative. So hemoglobin, it is high in the maternal fetal twin to twin transfusion and the delayed cord clamping, and the low reticulocyte count in case of uh, breast milk jaundice, Kifel hematoma, and enterohepatic circulation. Reticulocyte count is high and the blood smear there is a sepsis and septicemia and disseminated intravascular coagulation, and the sign of hemolysis in case of congenital hemolytic anemia and intrauterine infection. The management of neonatal jaundice. The management of unconjugated hyperbilirubinemia primarily aim to keep the free indirect bilirubin level within a safe limit of neurotoxicity till spontaneous decline in hemolysis and maturity in liver function. However, these safe limits are not well defined, depend on the gestational age, birth weight, and the coexisting problem that impair blood-brain barrier. The important measures to facilitate bilirubin excretion and the limit indirect hyperbilirubinemia include phototherapy, exchange transfusion, and ancillary measures. Phototherapy in neonatal jaundice. The phototherapy is most widely used method to prevent and treat unconjugated hyperbilirubinemia or indirect hyperbilirubinemia and avoid the need for exchange transfusion. The principle of phototherapy in unconjugated hyperbilirubinemia. In the phototherapy, an icteric newborn is exposed to the specific band of light frequency. There is a 425 to 475 nanometer that leads to photoisomerization of neurotoxic unconjugated bilirubin present in the skin to the non-toxic isomer, which are then excreted through the normal channels. In addition, phototherapy also reduces bilirubin level by photooxidation as well as by enhancing hepatic excretion of unconjugated bilirubin into intestinal lumen. The cutoff unconjugated bilirubin level for phototherapy and exchange transfusion milligram per dl. When there is an uncomplicated full-term baby, when there is less than 24-hour phototherapy at any time, and when there is a full-term baby between 25 to 48 hours, give phototherapy. When the bilirubin it is 12 to 15, and do exchange transfusion when the bilirubin is 20 to 25 milligram per dl. When the baby's age is 49 hours to 72 hours, phototherapy given when the bilirubin level 15 to 18, and exchange transfusion do when the bilirubin level 25 to 30 milligram per dl. When the baby's age is more than 72 hours, full-term baby give phototherapy between 17 to 20 hours and give exchange transfusion when the bilirubin level 25 to 30 milligram per dl. In case of preterm or the sick full-term baby, when the birth weight is less than 1000 gram, if give phototherapy at any bilirubin level and do exchange transfusion when the bilirubin level is 10 to 20 milligram per dl. When the babies it is preterm and sick and the birth weight between 1000 to 1500 gram, give this phototherapy between 7 to 9 milligram per dl bilirubin and 12 to 15 milligram per dl give exchange transfusion. When this full-term baby, sick baby, the birth weight is 1500 gram to 2000 gram, give phototherapy when the bilirubin is 10 to 12 and give exchange transfusion when the bilirubin is 15 to 18 milligram per dl. When these babies, sick baby, full term and birth weight is more than 2000 gram, give phototherapy between when the bilirubin level 13 to 15 milligram per dl and give exchange transfusion when the bilirubin it is 18 milligram to 20 milligram per dl. So these are the indication of bilirubin level and the gestational age and the birth weight in case of unconjugated hyperbilirubinemia. The procedure for phototherapy. Phototherapy is provided by a prolonged exposure of the baby to the specified frequency of photo emittance under overhead phototherapy units. The important prerequisite for effective phototherapy are the light source should provide an irradiance it is more than 10 to 15 microvolt per centimeter square per nanometer within range it is 400 to 500 nanometer range at a level of the baby skin monitor with the flux meters. So it is the source of this phototherapy and the skin of the baby. This distance is 45 centimeter or a 14 inch. The source should also covered with perplex as a shield to cut off harmful infrareds. So to prevent this cover the eyes, prevent retinal damage, and prevent and also covers these genitals uh, to avoid sterility. And the distance between the babies and the light source it is 45 centimeter or a 14 inch, and the baby should be fully covered except eyes and genital region to avoid radial injury to sensitive organ. There is retina and testis. And adequate breastfeeding is must to avoid dehydration due to insensible loss. Add 20% of extra fluid for a maintenance requirement of the if the baby is on IV fluid. Phototherapy is given continuously except during the breastfeeding with intermittent bilirubin monitoring. Exposure to the sunlight is not an alternative to phototherapy and sorry, may be harmful due to prolonged exposure to the ultraviolet rays. The modification, use of green tube light or halogen or CFL or a LED bulb or a fiber optic light source instead of conventional blue light to provide desired irradiance of the light. Intermittent phototherapy. Intermittent phototherapy for 6 to 8 hours. There is a 2 to 3 hours gap is as effective as continuous phototherapy, though with potential risk of more DNA damage. The double surface phototherapy, there is a continuous phototherapy and intermittent. Second, single surface and the double surface phototherapy to expose front as well as back surface of the baby. Allow faster reduction in bilirubin level. Intensive phototherapy, the lesser distance between light source and infant, it is 15 to 20 centimeter, may be more effective, but it is not recommended due to risk of thermal injury to the baby. So keep the distance between 45 centimeter, source of the light and the skin of the baby. The effectiveness of phototherapy depends on initial bilirubin level, surface area of exposed skin, gestational age and the weight of the baby, quality and the distance from light source. Although riboflavin supplement appear to increase it effectively, it is not commonly used due to probable risk of DNA toxicity. The complication of phototherapy. Although phototherapy is safe and non-invasive, intervention following complication may develop in some of the cases. Extent second management for neonatal hyperbilirubinemia indirect, there is extent transfusion. Extent transfusion is the most effective method to reduce indirect bilirubin level indicated only in severe hyperbilirubinemia when the bilirubin is more than 20 milligram per dl. The principle of exchange transfusion. Exchange transfusion aim to remove partially hemolyzed antigen-coated RBC as well as unmatched antigen from recipient circulation and replace them by unsensitized donor RBC and reduce circulating bilirubin metabolites. Indication, although principally used to control indirect hyperbilirubinemia, exchange transfusion may also be used to remove other toxic product from the blood. The type of donor blood used, there is Rh hemolytic disease of newborn, so give Rh negative blood with ABO group of the baby or Rh negative blood matched with mother and the baby. Dehydration due to insensible water loss. Now, these are the side effects of this phototherapy. There is a dehydration due to insensible water loss, loose green stool due to bilirubin catabolites, hypothermia or hyperthermia, phototherapy rash, bronze discoloration if erroneously given to case of conjugated hyperbilirubinemia due to formation of isomer bilifusine, and the late side effect of phototherapy, there is a cellular damage to the eye, there is a retina and genital, leads to retinal damage, sterility, and skin cancer. These are the side effects of phototherapy. ABO, ABO or hemolytic disease of newborn, give blood, there is a O negative, Rh specific, there is a low anti-A or low anti-B titer. Other indication of this exchange transfusion, it is ABO and Rh group of the baby. In case of exchange transfusion, the volume, what is the volume of exchange? Usually, double of the baby blood volume, there is a 80 ml per kg needs to be exchanged for effective results, which reflects more than 85% of the baby's blood and bring down bilirubin level. It is about 50% of pre-exchange value. And the route of this exchange transfusion. Usually, the umbilical vein is cannularized for exchange transfusion due to its size, though peripheral vein may be used. If umbilical canalization is not possible or a umbilical sepsis is present, normally the umbilical vein may be cannularized till 5 to 7 days. Indication of exchange transfusion in case of indirect hyperbilirubinemia, when there's an early prophylactic, there's an exchange transfusion in Rh hemolytic disease of newborn, when there is a cord bilirubin level more than 5 milligram per dl, when the cord hemoglobin less than 10 milligram per dl, when the bilirubin rise more than 1 milligram per dl per hour despite of phototherapy. These are the indication of exchange transfusion. Also, when there is a critical indirect bilirubin level, it is more than 20 milligram per dl, it is an indication of exchange transfusion. Also, there is a continuous bilirubin rise despite of this phototherapy, give this exchange transfusion. When there is a severe anemia with CSF or hydrops fetalis or the PEG cell volume it is less than 35, it is an indication of exchange transfusion in the newborn with this unconjugated hyperbilirubinemia. When there is a severe neonatal septicemia, it is an indication of vaccine transfusion. When there is a baby with disseminated intravascular coagulation, give this vaccine transfusion with fresh heparinized blood. So these are the indication of vaccine transfusion. Also, in case of severe polycythemia with hematocrit more than 65, give partial vaccine transfusion. When there is an inborn error of metabolism, there is a hyperglycemia, it is an indication of vaccine transfusion. So, what is the methodology to give vaccine transfusion? The basic steps include opting free flowing venous access and connect three-way cannula and draw 10 cc baby's blood for pre-exchange serum bilirubin and electrolytes level and withdraw 10 to 20 ml of aliquot of baby blood and then replace it with equal volume of donor blood and repeat the cycle till desired volume is exchanged. Monitor for the complication of exchange transfusion. After each 50 ml of exchange, 1 ml of 10% calcium gluconate should be infused in ACD or CPD blood is used to prevent bleeding tendency and send last baby's blood sample at the end of exchange transfusion for post-exchange bilirubin or electrolyte estimation. So, which are the complications of exchange transfusion? Metabolic complication, there is a hypocalcemia, hypoglycemia, and acidosis. Infection, due to this exchange transfusion, there is a umbilical sepsis, peritonitis, septicemia, and necrotizing enterocolitis. And traumatic complication, there is a cord bleeding and catheter injury due to exchange transfusion. And due to exchange transfusion, there is a volume overload. So these are the complications of exchange transfusion. Also, due to exchange transfusion, there is a hypothermia, and also there is another complication. There is a late anemia due to lesser lifespan of infused RBC that necessitate top-up transfusion. Third management for this unconjugated hyperbilirubinemia, there's ancillary measures. The following measures, though of a limited efficacy, are useful to adjunct to phototherapy and exchange transfusion in neonatal hyperbilirubinemia. IV albumin infusion, there is a zero point 0.5 gram per kg to bind free bilirubin, which is neurotoxic. Intravenous or oral phenobarbital, there is a 5 milligram OD to enhance this UDPGT activity and adequate breastfeeding to facilitate growth of gut flora and orally there is a bilirubin binder, there is a agar to prevent enterohepatic circulation in case of unconjugated hyperbilirubinemia. The management of blood-brain barrier impairing condition, there is hypoxia, acidosis, and the sepsis management by this antibiotic, IV fluid, and oxygen, and avoid drugs known to displace bilirubin from or albumin binding site. There is avoid sulfur drugs. So these are the ancillary measures for the management of unconjugated neonatal hyperbilirubinemia. Other modalities with equivocal results include intravenous immunoglobulin to bind these Fc receptors in hemolytic disease of newborn and synthetic metalloporphyrin to competitively inhibits heme oxygenase. There is a limiting enzyme for bilirubin synthesis. So there is a intravenous immunoglobulin for the management of unconjugated hyperbilirubinemia. So today's remark of this unconjugated or neonatal jaundice or neonatal hyperbilirubinemia, there is all neonate should be monitored clinically for appearance of jaundice during the first most natal week. In case of discharge, before 72 to 96 hours from the hospital, though assessment risk factor for severe jaundice should be done in all the baby. This assessment should include clinical examination of the baby, and if feasible, there is a biochemical screening, there is a serum bilirubin. In neonate with a significant jaundice, investigation should include blood group of the mother and baby, cum test, evidence for hemolysis, there is a hemoglobin electrophoresis, and the G6PD assay in area known to have high prevalence of G6PD deficiency. The decision to initiate phototherapy or exchange transfusion based on gestational age of the baby, postnatal age, risk factor, and clinical status of the baby. Phototherapy units should be proven safety and provide maximum irradiance to the maximum possible surface area. And the neonate with significant hyperbilirubinemia should be followed up for hearing loss and other neurodevelopmental sequelae. So follow up for hearing loss and other neurodevelopmental sequelae when baby presented with severe serum bilirubin more than 12 milligram per dl. Thank you.
Thank you, sir, for your wonderful presentation. We have some questions from our audience. If you'd like to take that up.
Yes.
Thank you, sir. So, sir, the first question from our audience is, could you discuss the management strategies of the different type of neonatal jaundice, including psychological, pathological, and breast milk jaundice?
So in case of physiological jaundice, when there is a bilirubin, it is uh, less than there is a 10 milligram, and in case of preterm, it is less than uh, 15 milligram per dl. Only this phototherapy is an indication. But when you do exchange transfusion, when there is a bilirubin is more than 10 milligram percentage, and associated complication like septicemia or hypoglycemia or DIC, when there is a all I already told there is a rising, there is serum bilirubin, there is a 5 milligram per hour, then there is an indication of exchange transfusion. And also we uh, we can manage this neonatal jaundice by this intravenous immunoglobulin and this uh, intravenous albuminis and agar therapy.
Thank you so much, sir. The next question from our audience is, how does bilirubin metabolism differs in newborn compared to older individuals?
Due to this, in case of the preterm baby or the low birth weight baby, there is immaturity there is of liver, uh, uh, immaturity of the liver. So there is a the liver enzyme, they are not properly working for bilirubin metabolism, and there is a rise of serum bilirubin. So due to the in case of preterm baby, there is a liver immaturity, and there is a also dysfunction of the liver enzymes, and it leads to bilirubin increased serum bilirubin, and there is a hyperbilirubinemia.
Thank you so much, sir. The last question from our audience is, what are the risk factor for severe neonatal jaundice and how do you assess these risks in a clinical setting?
So, so in case mostly there is a jaundice. There are the two types. One is a physiological jaundice and the pathological jaundice. I already told when there is a within 24 hours of the life jaundice is a this pathological jaundice, and the most common cause are a hemolytic disease of the newborn. When there is a jaundice, uh, on the palm and sole, it is a severe jaundice. When there is a jaundice, more than the 2 weeks, there's a 14 days, there's a severe jaundice. So these are all causes of pathological jaundice. Also, when there is a baby is sick, there is a hypoglycemia or DIC or kernicterus, then it is a severe jaundice, severe pathological jaundice, and the manage accordingly. I will be told when there is a complication of this unconjugated hyperbilemia with bilirubin more than 20 milligram per DL, do exchange. Main therapy is phototherapy, but when there is a bilirubin more than 20 milligram, then exchange. If it is 6 baby, there is with hypoglycemia, septicemia, and the DIC, then exchange transfusion. So basic management of this severe jaundice, one is phototherapy and second exchange transfusion.
Thank you so much, sir, for answering all our questions. So, with your permission, we would like to conclude today's session. Any last remarks from you, sir?
So whenever there is a jaundice, neonatal, you see the case of neonatal jaundice. If it is first day, always it is pathological jaundice. Most common jaundice in the newborn, it is a physiological jaundice. But in case of the physiological jaundice, due to certain risk factor, when there is a preterm baby is there, or associated dehydration or acidosis, electrolyte imbalance, and hypothermia or hypoglycemia, there is a prolonged physiological jaundice. So when there is a first day jaundice, or it is more than 2 week duration jaundice, or a jaundice on the palm and sole, it is a severe jaundice. And basic therapy for neonatal jaundice, one is phototherapy and second is exchange transfusion.
Thank you so much, sir. With your permission, I would like to conclude today's session. Thank you so much for joining us today.
Okay, thank you. Good day.